Hello everyone, greetings from Australia. It's almost summertime here and we've just come out of hard lockdown here in Melbourne. My name's Dr. Sandra Lucier. I'm an intensivist and general physician, which is known as an internal medicine specialist in some parts of the world, based at the Austin and Northern Hospitals in Melbourne. I'm also the chair of the Women in Intensive Care Medicine Network, which is a network which aims to improve female representation in clinical, research, academic and leadership positions through research, networking and advocacy. First up, for this amazing conference, we'll be taking a journey through bronchoobstructive disease with three excellent talks from three Australian intensivists. So firstly, just a few housekeeping issues. Questions for the panelists will be at the end, so please place any questions you have in the chat function and they will be relayed to me. There'll be 10 minutes for questions at the end. I'll introduce our speakers next. Firstly, we have Dr. John Zorbas, who will be discussing the utility of airway pressure release ventilation in COVID-19. Dr. Zorbas is a specialist emergency physician based in Perth, Western Australia, and is a tireless advocate for trainee doctors and is heavily involved with the Australian Medical Association, holding several positions with the organisation over the years. He's also drafted several key policies and audits relating to safe working hours and doctor wellbeing. Next, Dr. Jai Darwal will be speaking on thunderstorm asthma. Dr. Darwal is an anaesthetist and intensive care specialist based at the Royal Melbourne Hospital in Melbourne, with dual appointments at the University of Melbourne as a senior lecturer in critical care education, and an honorary senior fellow for the Centre for Integrated Critical Care. He's completed a Masters of Epidemiology and has research interests in frailty and perioperative critical care. And it is the subject of his current PhD. His research focuses on identification, risk stratification, and improving outcomes for frail ICU and surgical patients, for which he was awarded the Emerging Researcher Scholarship for the Australian New Zealand College of Anaesthetists. And finally, we'll be hearing from Dr. Jane Lewis, who will be speaking about the Great ICU Divide, asthma versus COPD. Dr. Lewis trained in emergency medicine and intensive care medicine in the USA before moving to Australia. She has been working as an intensive care specialist at Austin Health in Melbourne since 2015. She's interested in anything respiratory critical care and is certainly our go-to person for any respiratory critical care questions at the Austin Hospital ICU, as well as end-of-life care and organ donation. And she currently holds a medical donation specialist role with Donate Life Victoria. So without further ado, I will hand over to Dr. John Zorbas. Take it away, John.
My talk is looking at the use of airway pressure release ventilation in COVID-19. I am based in Perth, as Sandra has mentioned, and COVID's been a little bit different for Australia, and especially in Western Australia, as I'll touch on in a second. Unless you haven't been here with us for 2020, COVID-19 has been a huge impact on not just communities, but hospitals and intensive cares across the world. Up above 50 million cases quite recently, and deaths are now north of 1 million as well. For those who are not familiar with the structure in Australia, we are a federation, multiple states and territories, and most of the health responsibilities, especially hospital services, are provided by state governments. That's relevant to how COVID has played out in Australia because we are a large island with a relatively small population for our size. And so the primary means of control for the spread of COVID in Australia has been border closure, quarantine, and limitation of movement. Because of that, we've had fairly low numbers compared to the rest of the world. If you look at our daily reported cases over 2020, no day has been north of 1,000 cases. And you can see there are two main waves there, a first just south of March and a second that peaked after July. We're now experiencing another outbreak in South Australia, which at this moment is about 20 to 23 cases last I checked. So I'm based over in Western Australia, over just on that very edge of the map over there, and we had a very small number of cases which will be relevant for this presentation as I explain what we looked at. So what's the timeline look like for us? Well, the first case was identified in December of last year. And for Australia, the first case that we were able to identify was a return traveller from Wuhan in January 25th, and that was in Melbourne. 5 days later, at that point, it was quite widespread in the rest of the world and was declared to be an international public health emergency. For us in Perth, the first case admitted to an intensive care unit was in February, and the last case to be admitted in that wave 1 period was shortly, 2 months later, April. And it was only in June that the last wave 1 patient was discharged. So at this stage, COVID was still a relatively new disease. It still is in a lot of ways, but at this stage, we were still looking at methods, treatments, ways that we could improve the treatment we were providing in our intensive care units. And we looked at APRV. And the main reason we looked at APRV was because the similarity between COVID-19 pneumonitis and ARDS, at least in the early stages. And APRV is a treatment for ARDS. We know that opening the lung in conventional low tidal volume ventilation needs a higher PEEP. The mean airway pressure is driven mostly by the PEEP because of the nature of the ventilatory cycle. And because of that, you have limited room to move on driving pressure, because as you push that PEEP up, you do get higher and higher peak pressures, which lead to increases in ventilator-associated lung injury. In APRV, we flip the ventilation curve on its head. And so the P high, the pressure high, and the T high, the time spent at that pressure high, recruits lung, but it also drives the ventilation, allowing for higher mean airway pressure, but while also allowing for a limitation of the peak pressure that you're applying. So you get a higher mean pressure, and that in theory should help with severe hypoxemia. The biggest RCT that's been done in this space was done by Zhao and colleagues in 2017. And it was an RCT that took 138 patients with severe ARDS who had only been intubated for a short period of time. And they were randomized to either ARDSNet low tidal volume ventilation or APRV. And the way that APRV was used in these patients was quite protocolized, very clear onset and offset and weaning protocols. And what they found was that there were a high number of ventilator-free days within a month. There were a high number of successful extubations, a lower number of tracheostomies, and a lower degree of ICU mortality. Later, 2 years later, we've got a meta-analysis done by Drs. Lim and Litton, comparing a number of APRV RCTs over time. And what they found was that there was a relative risk of 0.67, so an improved mortality with the use of APRV, and a 60-point increase in the PF ratio, so improved oxygenation, without a significant difference in the use of rescue treatments. So it seems like APRV is a good treatment for ARDS, or can be a good treatment for ARDS, potentially. So why COVID? Why look at APRV in COVID then? Well, these were patients that had a high prevalence of severe hypoxia and high numbers requiring mechanical ventilation. So Doherty and colleagues looked at 20,000 patients retrospectively in the UK. Prospectively. It was observational, but prospective. And more than half, so 55% of patients received high flow oxygen at some point during their admission, and 10% of those 20,000 patients were intubated. Similarly, Potter and colleagues did a systemic review and meta-analysis, looked at 44 studies with a total of 15,000 patients across the world. 34% of those patients died while they were in ICU, 83% if they were intubated. So in looking at ventilation strategies for COVID, we realized that there was definite equipoise in this area. There are no published ventilation strategies for COVID, and there still aren't at this point. So can we improve oxygenation and can we reduce mortality with something like APRV? In thinking about whether this was a useful treatment or not, we thought about our early COVID patients, and putting aside the problem with aerosol generating procedures and managing risk exposure to your staff, would you non-invasively ventilate your hypoxic patients? And the answer was generally yes, at least for us. So in early COVID, it seemed like this was a good treatment. And if hypoxia is your main problem, then increasing the P mean seems to be a good approach. We also felt it was important to explore methods that may be useful in resource poor settings. Now, this doesn't just pertain to low income or moderate income countries. We're also talking about what is essentially a mass casualty situation where hospital resources were being overwhelmed quite rapidly. And so technologies like ECMO are not reasonable at scale in a pandemic. And so something like APRV, while it still does require specialist ventilation and specialist staff, is less resource intensive than some of these rescue therapies. So we performed a multi-centre retrospective observational study. We involved 5 major hospitals in Perth, Australia. Perth has a population sort of between 2 to 3 million, last I checked. These were all patients with a positive PCR for COVID-19 and who required admission to ICU. Looked at all patients who were admitted during that peak one, that February and May period. Ethics approval provided from all 5 centres. And all clinical care was at the discretion of the intensivist. This was a retrospective study and it was observational, so we were limited in what we were able to do in terms of comparing like for like. There is one retrospective observational cohort study in progress in Nancy in France, but recruitment so far are 17 patients, and the outcomes are looking at the proportion of patients improving the PF ratio at 6 hours of APRV, so they're not looking at mortality outcomes. So what were our outcomes? Well, our primary outcome was survival to day 90, and looking at a Kaplan-Meier survival graph, but also using a Cox proportional hazard regression model with propensity score adjustment. And what we wanted to do, given that we were uncertain with how many patients we'd have, was to make sure that we were able to say that APRV was an independent predictor for survival. And so that required adjusting for the severity of their illness. There was also bootstrapping, resampling done to 1,000 samples to reduce overfitting bias with our primary outcome. Secondary outcomes included ventilator-free survival days to day 90, mechanical complications from ventilation, and the difference in days ventilated between survivors and non-survivors. So it was a bit of a double-edged sword, or a bittersweet outcome for us in this study, in that we only ended up having 25 ventilated patients admitted to those 5 ICUs over that time period, that 2-month window in Perth, which was very, very fortunate for us. And it's embarrassing to present research on COVID when we're talking about something that is currently affecting intensive care units all over the country, and where thousands of people are being admitted and mortality figures are still quite high. So it's a bittersweet success story for us, but that didn't help our research. So what we did have were patients who were treated and untreated with APRV, a split of 25 patients for 11 receiving APRV. Baseline characteristics were relatively similar. Well, they were not statistically different. The mean age for our patients was 70, and that is mostly as a reflection of a lot of these patients at this time were returned cruise ship passengers to Australia. And looking at markers of severity of illness, there was a similarity across the board there as well. The mean time to initiation of APRV was 1 day. So these patients were either started on APRV quickly or weren't started at all. And this may have to do with the familiarity with the use of APRV in Perth. It was used extensively in 2009 with in the way we dealt with H1N1 and the flu epidemic at that time. So there's perhaps more clinician familiarity with APRV. The median duration of APRV was 7 days. So these patients weren't really switched from ventilation mode to ventilation mode. They tended to stay on the mode they were commenced on, unless there was a reason to switch them off of it. Looking at concurrent treatments, what we found was that there was no significant difference in the concurrent treatments received by these 2 groups of patients. No patient received renal replacement therapy, remdesivir, tocilizumab, any other sort of specific experimental treatments at this point. No patients received ECMO, at least in our sample set. There was no difference in the use of hydroxychloroquine, azithromycin, lopinavir, ritonavir, or vitamin C, which were used in these early stages. And what we found was that the patients who did receive APRV had a lower probability of survival. So the survival curve for patients treated and untreated with APRV is presented here. There's a hazard ratio of 0.17 for survival. So the APRV group had a lower probability of survival compared to conventional ventilation, or a relative risk or a hazard ratio for survival of 17% for survival compared to conventional ventilation. So it's quite a marked difference in a very small sample set, and we will talk about that later in the talk. As I said, we wanted to examine predictors for severity of illness. Was APRV used as a rescue technique, and is this why we were seeing this mortality difference? And so we looked at predictors of mortality such as Apache scoring, initial PF ratio, baseline FiO2, etc. And as you can see there was no difference with propensity score adjustment. So we did this to reduce confounding as much as was statistically possible within the realms of our sample size. And we were able to demonstrate that there was a difference in the severity of illness and the use of APRV as a rescue technique in these patients. It's also accounted for the use of inhaled pulmonary vasodilator therapy, prone ventilation, and while the association with APRV was reduced, it was still unchanged in terms of significance. Looking at secondary outcomes, there was a difference in ventilator-free survival days up to day 90 and ventilator-free days amongst survivors, favouring the group that was untreated with APRV. There was only 1 incidence of pneumothorax. Now that was in the APRV group, but that was just 1 patient, so it's hard to draw strong conclusions from that. no significant differences otherwise. And here we've demonstrated, that there was a tendency to higher driving ventilating pressures in APRV and delayed deteriorations in respiratory compliance, and a tendency to deliver over 6 mils per kilo for tidal volume in the APRV group. So not what we were expecting to find. So the use of APRV was significantly associated with a reduced 90-day survival, higher driving pressures, and a delayed deterioration in compliance. When we tried to use propensity analysis, the harm signal remained, was still present in our analysis. This is contrary to what we were expecting to find. Now, this led to a fairly wide discussion as to why we found these results. So first and foremost, there are inherent limitations in such a small retrospective observational cohort. Now, it's really hard to draw strong conclusions from what was ultimately a study of 25 patients. What we would like to do would be able to repeat this in a much larger population group, and we're limited in our capacity to do that in Australia. Is this ARDS or not? There has been a lot of discussion about this, and in particular, the correspondence between Gattinoni and Boss and colleagues in the European Respiratory Journal about whether this is ARDS or not, and compliance phenotypes. It's far from discrete, and there is no set comment there on whether this is ARDS or not. Is it behaving like ARDS in an early stage and a late stage? Does it prevent like ARDS throughout the duration of the illness? Now, all of our patients had fairly low compliance, but we don't fully understand the disease process at present. Looking at the literature, there is a tendency towards low compliance rather than high compliance. Being an observational study, there were multiple ventilation modes used. So the conventional ventilation group and the APRV group weren't standardized in the ventilation settings. Patients were put on PCV, PSV, bi-level, various types of ventilation and various durations, although there wasn't a lot of change between APRV and conventional ventilation. They did stay true to their groups. There was a significant variability in the P low and the P high that was used for the APRV, so there is potentially a need for standardization of the use of APRV, much like there was in the RCT done by Zhao and colleagues. Or at least there's rationale for progression or weaning protocols. I suspect that unfamiliarity, while I said that APRV was used extensively in Perth, I think in a new disease process, there's obviously more anxiety and more variability in how it is used, and perhaps that led to variation in both settings that we used and chart recall. And I've made a comment there about measurement bias. It is difficult with retrospective chart recall to draw conclusions on what we're seeing there. So where did we land at the end of this? We said that we would urge caution with the use of APRV in COVID. Safety and efficacy of APRV needs to be established by a large observational trial or a randomized control trial. Ideally, taking the work that we've done and replicating in a larger observational population would be helpful to make sure that the harm signal we're seeing there is not due to APRV being used as a rescue, despite our efforts to reduce confounding from a statistical point of view. These studies may be assisted by a standardized approach to APRV and closely paying attention to lung compliance and driving pressures, tidal volumes, to make sure that we are sort of still within the realms of low tidal volume and protective lung ventilation. Thank you very much.
Thank you. Many thanks for the opportunity to speak on, I suppose we're segueing from a disease we've fortunately not seen very much of in Australia to a disease which we're the world leaders in, and that's thunderstorm asthma. This presentation will hinge on what has turned out to be the largest episode of thunderstorm asthma in history. That was a number of years ago now. So in 2016 in my hometown of Melbourne, or home state of Victoria in Australia. And I'll go through that epidemic, which was the largest outbreak of critically ill patients stemming from thunderstorm asthma, and some of the learnings that we've come to about the disease. So it is almost exactly 4 years ago. Today's the 18th, so in 3 days it'll be 4 years since this really quite unprecedented outbreak of what was thought to be quite a rare disease, but it's actually since come to light that it's probably a bit under-recognised. It was quite a brutal night for those of us that were involved in the response in Victoria, and I'll take you through some of the figures and so on shortly. It made international news media. It was such a big event. So it was the most lethal event of thunderstorm asthma on record as well. So initially thought to be 8, subsequently confirmed to be 10 people deceased as a result of this outbreak. One of the most lethal aspects that's since come to light of this disease was how overwhelmed our emergency services were in Victoria. This is a graph of the telephone calls to our emergency response 000 line, which increased some 700% during the episode. Really, to a degree that our services weren't built to deal with. The resulting presentations to emergency departments was also unprecedented. So almost the same degree, 600-700% increase in respiratory presentations to both public hospitals and private hospitals with emergency departments in our state. So we understand a lot more about it since this episode. There's some aspects of the disease that are still a bit mysterious, but it's widely accepted that what happens in an outbreak of thunderstorm asthma is this massive liberation of so-called aeroallergens, predominantly pollen, and in our area that's ryegrass in Victoria. There's also a role for other pollens, tree pollens, and airborne fungi. Alternaria is a cause reported from particularly the Northern Hemisphere. And there's certain characteristics of a storm that have to be fulfilled for this outbreak to occur. And we don't understand all of it. So why don't all storms cause this? And why don't all days of high pollen counts cause this? Probably what is required is this particular unique phenomenon known as an outflow wind gust, which is ahead of the storm front. So the first event is that there's sweeping up of widespread pollen over a large area, which is then exposed to the moist conditions in the cloud mass. The pollen granules rupture, and then this outflow wind gust ahead of the storm front brings it at dramatic pace over a large area. And it's this unique set of conditions that's required for an outbreak to occur. So on the left here this is actually a slide from the night. This is a ryegrass granule rupturing. You can see that up in the top left corner. And the sort of dusty, smeary appearance to the slide is all these hundreds, thousands of little pollen granules that are being liberated. Alternaria, the fungus that's on the right side of the screen, probably less of a role in our area of the world. It is truly a global disease. So these are some of the hotspots or wider scale epidemics that have been reported from around the world prior to our event in 2016. And really, from most of the major continents on Earth. Prior to our outbreak, the largest episodes had occurred in London, actually, so an urban area, in 2013, some 600 odd patients, and in Iran, actually in the same year, over 2,000 patients were affected then. But we are very much the epicentre in Australia. And in my state of Victoria, every sort of 5 to 10 years, it seems we have a major outbreak, usually in spring, well, actually always in spring and in the month of November. And it almost always is associated with or is subsequent to a time of high rainfall, with really a lot of that grass ready to go. We've discovered a lot about the disease from our outbreaks locally. So grass allergy is very common. Interestingly, there's less of an association with asthma in patients that are affected. One of the earliest case control studies out of Wagga Wagga. So this is a satellite image of Wagga in Australia, which is a really high risk area for thunderstorm asthma. You can see it's surrounded by lush grazing pastures. So hay fever, common, ryegrass allergy, very common, with a protective effect demonstrated from inhaled corticosteroids. This is what the rainfall over spring leading up to this event looked like in Victoria. And it really was a very wet period of time. In fact, for most of the state, it had the highest rainfall recorded. And what that led to, these are some vegetation graphs, over the preceding 3 years. You can see, so green is more vegetated, basically, satellite imagery. So 2014, 15, and then 16 was a very lush year. And in retrospect, the conditions were perfect. But as I said at the start, it's not always on days of extreme pollen counts. And in fact, the 21st of November 2016, although a high day of pollen count, had been exceeded on what, 3 occasions that month alone. And in terms of the cumulative pollen count over 2016, it really wasn't a high pollen year comparative to even the average. It was a below average year. So it really is that unique confluence of conditions that's required. Here's the thunderstorm. These are some Bureau of Meteorology in Victoria rain graphs. So you can appreciate, those of us that are used to looking at these radar images, it's a really quick front that's moving over there. But interestingly, not a lot of rain got dropped. So it wasn't a particularly wet storm. It was the speed and wind that was associated with it that really was the important factor. So what do we know about critical illness in thunderstorm asthma from past outbreaks? Well, not a lot. So these were the 5 previous reports from outbreaks. The London episode I mentioned, sorry, that was in 1994, Iran in 2013. And really, you know, a handful of patients had presented over previous episodes, you know, under 10 in all of them. So we really didn't have a good handle on what it was about critical illness or patients that were more predisposed, I guess, to developing severe thunderstorm asthma until this event. So our aims in interrogating this were to try and work out a little bit more about the disease. Is it just a severe exacerbation of what we call usual asthma, or is there some unique aspects to this particular disease? Who are the patients that go on to develop life-threatening bronchospasm? Can we risk stratify them for prevention in the future? And, you know, can we find out a little bit more about the factors that I've mentioned already, pollen, particle counts and weather, to help stratify risky days going forwards? So we conducted a study, a retrospective observational study of all of the ICUs in our state, and an in-depth case analysis of each patient that presented to them on the day. We obtained a lot of extra data from very helpful bodies, including our Bureau of Meteorology, the Botany Department at the University of Melbourne, who are very experienced in pollen analysis, the EPA, and our local intensive care society, ANZIS. As I said, we interrogated every record of patients admitted over the 21st and the 22nd of November to capture those that were admitted with asthma and indeed thunderstorm asthma. And collected a wealth of data on both the patients and the conditions at the time. So these are the intensive care units in our state. Blue are more regional ones, and red are the metropolitan ones. And these were the affected ICUs, with 1 private ICU in yellow there. So 15 ICUs managed thunderstorm asthma patients. There were 35 patients in all that presented on the night of the 21st of November. You can see here, this is over the calendar year of 2016 with respiratory presentations, asthma presentations and respiratory arrest. And it really was a fairly unique event in that year. So what did it mean in terms of resource allocation across the state? Well, we have, in terms of bed stock in Victoria, in 2016, we had just over 300 available beds. So it meant that about 1/5 of all of the beds in the state were occupied by a thunderstorm asthma patient at a cost of around $1/3 Australian dollars. So who were the patients then? Well, they were young, and what's interesting is that was certainly borne out in the coronial data. So the 10 deaths ranged in age from 20 up to 57, with the exception of the 57-year-old, all were aged in their 20s, 30s and 40s. So they were a very young cohort admitted to ICU. They were predominantly males. And interestingly, we saw this signal of 1/3 of patients admitted from either Asian or subcontinental ethnicity. And I'll talk to that more shortly. A large number of patients presented after respiratory arrest, and indeed cardiac arrest was seen in the community as well. 5 patients died, and the rest survived with, so survivors actually went home with no neurological injury. So that was good. Very interestingly, all patients who presented to ICU had a past history of asthma, and only 40% had a past history of allergic rhinitis, with very few having a known grass allergy. How does that compare with previous reports? So out of past epidemic thunderstorm asthma reports in the literature, asthma is common but by no means universal. But by far and away more common is a diagnosis of hay fever or allergic rhinitis. So that was a little bit skewed in our cohort the other way. What about asthma management? So although all patients essentially bar one had been prescribed an inhaled bronchodilator for relief of asthma symptoms, only a third were taking a preventer. And of those that suffered a respiratory arrest, only 15% were on an inhaled corticosteroid. These patients were sick, very high Apache 3 scores, and certainly very high in those suffering a respiratory arrest. Patients who suffered an arrest were ventilated for a longer period of time, and those patients stayed for a longer period of time. But interestingly, across the board, fairly low ICU length of stay and mechanical ventilation hours. And that's reflected in this graphical data. So this is ventilatory support over day 0 to day 8 in ICU. And you can see, although over a third are ventilated at the start, by day 2, that's under 1/3. The same applies to patient disposition. So by day 2, only a third of all the 35 patients were remaining in the ICU. In fact, about a third of them had gone home at that point. In terms of therapies that were required, again, by day 2 or certainly day 3, almost all the patients were liberated from even inhaled bronchodilator therapy, and very few patients requiring more intensive rescue therapies by then. So the picture that emerges is one of very severe, life-threatening bronchospasm, but with very rapid resolution. And that plays out in our physiological data as well. So although they're very sick in terms of their blood gas analysis at admission, so median CO2 over 100. This is in millimeters of mercury for our units in Australia. But by day 1, essentially normalised in terms of pH and gases. Plateau pressures back to normal really by day 1 as well. How does that compare with usual asthma presentations? So we compared the thunderstorm asthma cohort with all other 1,000-odd patients that were admitted to an ICU in Australia with asthma during 2016. And that signal of rapid resolution was played out. It was much more mortal, so only about 1% of all asthmatic patients died, critically ill asthmatic patients over that year, but 14% of the thunderstorm asthma patients did. But as I say, length of stay was much shorter. ICU length of stay, particularly among survivors, was shorter as well. So rapid resolution of disease. I'll come back to the ethnicity angle now. So interestingly, I mentioned a third of all patients admitted to ICU were from an Asian or subcontinental background. And of those that had suffered a cardiac arrest, half of them were. And this really compared, this was very disproportionate compared to that of the population of the catchment areas that we served. And this has been borne out in multiple other publications stemming from this event. And indeed, prior allergy and atopic data certainly bore this out prior to this event, is that patients from these ethnic backgrounds are more likely, particularly when moving to areas of high allergen load, pollen counts in particular, are much more likely to develop allergic responses. So there's an at-risk cohort. How did the weather and pollen counts correlate? Well, they correlated almost perfectly. So these are 5 weather stations, A, B, C, D, and E, across our affected region in the state. This is Port Phillip Bay, the major bay that Melbourne's based on. And you can see over that period of time from 5 p.m. through to 7 p.m. as the storm front passed over that 2-hour period of time, the storm front arrival, which is exhibited with a change in humidity, coincided almost perfectly with pollen count increases at each of the weather stations, lending support to this theory of the outflow phenomenon ahead of the storm front, leading to indeed dramatic increase in aeroallergens. So we had a lot of input into the development of guidance after this event, and this is our state government and Department of Health recommendations for spring now in Victoria. And we risk stratify patients based on their symptoms at rest. So patients that have allergic rhinitis during this period, this at-risk period of thunderstorm asthma, they should be on at least intranasal corticosteroids. Those that have asthma should be taking inhaled corticosteroids, and those with the combination should be on both for that period of time. There's also guidance that's released contemporaneously in the event of a high-risk storm being identified, and public health alerts now go out advising the community on tips for thunderstorm avoidance, which are pretty straightforward. Stay indoors, windows closed, avoid unnecessary outdoor exposure, air conditioning on, and have your asthma action plan at hand, and take some inhaled corticosteroids if you're at risk. And fortunately, with those recommendations in place, and I think a fairly dry intervening 4 years since 2016, we've not had a major outbreak since then. What's interesting is for those of you in South America, we're now getting the La Nina, which is the wet summer that's anticipated. And that was the case in 2016 as well. So we have a very wet spring and summer forecast. And so it might well be that 2020 sees some more risky storms heading our way. So if you want to read more about it, we've published on this phenomenon, and goes into a lot more detail, some of the things I've touched on today. So the take-home messages, I guess. So for thunderstorm asthma, critically ill thunderstorm asthma patients tend to be asthmatic, and there is this male predominance and Asian subcontinental predominance as well. Inhaled corticosteroids are protective and should be taken. And it is this picture of rapid resolution of bronchospasm, fitting with more of an allergic versus perhaps your usual asthma infective triggers. We've, I think, shown quite definitively that there's a confluence of storm front and pollen arrival. And I've gone through the protective factors or preventative factors that we institute in our state here. Thank you very much. I'll stop my screen share.
Thank you, everyone. I get to finish up, and I'm going to give you a whirlwind tour of the last 20 years. And for those of us a little bit older, I just have to remind you that 20 years ago was not 1980s, which it seems to feel that way, but instead it was in the early 2000s. So I'm dating myself right now. So I get to talk about asthma and COPD, and I'm here to really kind of review that they're a lot more similar than I think we realize. And it's a really lovely follow-up from Jay's thunderstorm asthma conversation and talk. Thank you, Jay. So asthma and chronic obstructive lung disease, they're both chronic respiratory diseases. And as we know, they've got a major cause of both morbidity and mortality worldwide. We also know that the etiology and pathogenesis of the diseases are actually very different. And that the asthma and COPD exacerbations contribute most of the morbidity, mortality, and the excess healthcare costs. We also know that the majority of the acute exacerbations, not the thunderstorm asthma, are often caused by respiratory viral infections. And the current therapies that are increasing in number continue to be effective at reducing symptoms. However, they are less effective in preventing exacerbations, and this is particularly notable in patients with COPD. So what are our definitions? So asthma, according to the Global Initiative for Asthma from 2020, is that asthma is a heterogeneous disease. It's usually characterized by chronic airway inflammation. Patients have wheezing, shortness of breath, chest tightness, and cough. But they also have variable expiratory airflow limitation. And when they're doing well, they'll actually have normal pulmonary function tests. This is in contrast to COPD and the GOLD criteria from 2020, which also show that it's a common, preventable, and treatable disease. And this is characterized by persistent symptoms and persistent airflow limitation. And this is due to either or airway alveolar abnormalities. And then there's this cool diagnosis called asthma and COPD overlap syndrome. And we're not going to really talk too much about that today. But patients tend to have a persistent airflow limitation, but they also have clinical features consistent with both asthma and COPD. So there's a huge global burden of disease, and I think this is really important because in 2015, which was only 5 years ago, 3.2 million people worldwide died from COPD, and this has increased significantly if you compare that to 1990. And if you look at the number of people who died from asthma, thankfully it's a younger patient population in general and a significantly decreased number of patients who die. And this is actually decreasing by a significant number compared to 1990. And we know that the prevalence of asthma is also increasing. The global prevalence of asthma is estimated to be 300 million and is currently estimated to be 300 million and expected to grow by greater than 100 million by 2025, which is only 5 years away. And by 2030, so in 10 years, we're expecting that COPD is going to actually go from being the 4th leading cause of death right now to being the 3rd leading cause of death. So viral infections, and we're going to just really briefly touch on COVID-19 since it is significant right now. We know that both patients with asthma and COPD are at risk of more severe outcomes with common cold virus infections compared to those patients who don't have chronic lung disease. And the first reports out of Wuhan in China showed that actually of the 140 patients who were hospitalized with COVID-19, they less commonly saw patients who had COPD, and they didn't have any patients admitted with asthma. And if you compare that to age-matched populations, you can see there's a significant difference. Calms and Co. in just recently, it's currently in press, reviewed their COVID-19 admissions from Belgium. And what they found was that the proportion of asthmatics and COPD hospitalizations was similar to the percentage in the general population, suggesting that asthma and COPD are not risk factors for hospitalization. They also looked at these patients and found that there was not a risk factor for ICU stay or death. Moving on, because this is our whirlwind tour of asthma and COPD in ICU, we're going to look at non-invasive ventilation of COPD. So in 1998, there was this study, and it's in Russian, but thankfully the abstract is in English. They looked at 58 patients, and what they found was the use of non-invasive ventilation in addition to usual care decreased the need for intubation as well as the decreased mortality in hospital stay. In the UK, they looked at 14 different hospitals and did a multi-center randomized controlled trial on general respiratory wards with patients who had mild to moderate acidosis. And they found that they had rapid improvement in their physiologic variables, and they had decreased need for invasive mechanical ventilation and decrease in mortality in patients who have COPD. And this was in 2000. In 2005, there was another study in a Chinese journal that looked again at a multi-center trial of 19 hospitals and 240 odd patients, and they compared for COPD patients the addition of NIV to usual care, and they also demonstrated that there was decrease in intubations, but they didn't find a change in mortality. In 2009 is this study from India, and they found very similar outcomes as well. This study is actually from 2012, and this is a US journal, and they noted that non-invasive ventilation for COPD was actually quite a late finding in the US. In Europe, they were actually using it a lot earlier, but by 2012, they were recommending that everyone be considering non-invasive ventilation if it's appropriate for someone who has an acute exacerbation of COPD. And in 2017, the Cochrane Group released this study looking specifically at meta-analyses of all these trials. Center randomized controlled trial as well, looking at about 50 patients, and they had similar outcomes as well. So the Cochrane Group did a meta-analysis in 2012 looking at non-invasive ventilation for severe acute exacerbations of asthma. And what they found was that it remains controversial despite its continued use. And this was in 2012. And if you look at the literature since that time, the number of the amount of use of non-invasive ventilation for acute asthma has significantly increased in use. So it would be interesting to see if there were any further studies, but their recommendation was that they would recommend multi-center randomized control trials. If these patients do require invasive ventilation for both COPD and asthma, there are some general principles, and we're going to just quickly review those. So the principles for invasive ventilation is to minimize dynamic hyperinflation, to provide controlled hypoventilation. We know that patients tolerate permissive hypercapnia and they tolerate the acidosis that goes along with that. The goal is to provide prolonged expiratory time and unload their breathing effort. Interestingly, in COPD, the recommendation is to consider using about 80% of their intrinsic PEEP that you would match with the external ventilator PEEP levels. In asthma, the recommendation is that you use very low PEEPs between 0 and 5 centimeters of water. And the data supports that in actuality for asthma, if you have high levels of PEEP, it's actually going to add to their auto PEEP instead of actually replacing it. So it will actually make their patients much more difficult to manage. And last but not least, of course, is to promote patient and ventilator synchrony, not dysynchrony. This is a very brief slide looking at post-extubation NIV. And as you can imagine, and from what Jay described, these patients with asthma tend to improve quite quickly, whereas COPD patients tend not to. But looking at post-extubation NIV as a Cochrane meta-analysis from 2010, in COPD it's recommended, and you can see that there's a decrease in risk ratio in favoring non-invasive ventilation versus remaining invasively ventilated, and in everyone else it's not recommended, and that includes asthmatics. From a medication standpoint, again, there is a lot of overlap between the two. So as you can tell from this very nice review from Tuxson and Hugh, the recommendations would be for inhaled beta agonists, inhaled anticholinergics, oxygen therapy is recommended, steroids absolutely. Antibiotics would be where it's a little bit different, because the majority of patients who have severe asthma exacerbations are going to be triggered by a viral infection. And then you can see the other ones that are quote unquote optional, depending upon how much rescue therapy you require for these patients. You note at the bottom that advanced care directives are different between the two as well. And it would make sense, because your asthmatics usually tend to be young, healthy patients who come in who require ICU care for a shorter period of time, whereas your COPD population tends to have significant pre-mort functional disability, potentially, especially as they have further exacerbations. If you look at the survival and quality of life of patients who have asthma, Alzir described 54 patients who had severe asthma requiring ICU admission, and that was from 2006, and about 40% required ventilatory support, and everyone was discharged home. We have data comparing 1996 and 2003 here in Australia, which showed actually a decline in the patients with asthma requiring ICU admission, along with a decrease in hospital mortality. And you can see that actually the 1.1% from 2003 matches what Jay just presented from 2016 of 1.1 to 1.3%. Of note, those who are mechanically ventilated in this population, about 6.5% died. If you look at UK data, it's fairly similar. Although a higher proportion of the patients in the UK died, a lot of those patients had actually had an out-of-hospital cardiac arrest prior to their admission from their severe asthma. This is in contrast to COPD, where there's a significant number of deaths every year. And the in-hospital mortality of COPD, there's a very large range, and it is interesting to read the different literature, but it does range between about 3 and 30%. This is a UK study looking specifically at the mortality of patients in the UK in multiple centres, and they have almost a 20% mortality in ICU, a 30% mortality in the hospital, and their 6-month survival, if they survive their ICU admission, is only 60%. We also know that if you have frequent COPD exacerbations, you're more likely to have a faster decline in your FEV1, impaired health status, and overall worse survival, and many patients often don't return to their own baseline level of health and functioning. So the real question is there a great divide between the two? They're both chronic obstructive respiratory diseases, and I hope I'm convincing you that there's actually a lot more similarities than I think we realize. We do know that both of them have a large world health burden. COPD is significantly more common than asthma, but asthma is actually becoming more and more common. And we also know there's a higher prevalence in younger working age population. Interestingly, and I think in the context of time, we're going to find out a lot more information, including whether or not these patients are more prone to long COVID. But at this point, the limited data that has been released, it seems like we have less admissions with COVID-19. And the question really is there more protective behaviors from this patient population with increased use of masks and less, leaving the house and compared to others? There's a lot of similarities for management, including the non-invasive ventilation, and there's fairly good data for that, mechanical ventilation, the medications, and overall the ICU general care. However, as stated, the mortality is significantly higher in our COPD populations, and it's actually increasing over time and is expected to be the third leading cause of death in the near future, whereas asthma is not anywhere near that. Thank you so much for listening, and I hope you enjoyed the whirlwind tour of the last 20 years, starting in end of 1990s. Thank you.
Thanks, Jane. Although I know probably the biggest difference I think between asthma and COPD is that in the middle of the night, I know who I'd much rather be ventilating, a bad asthma or a bad COPD. I think it's interesting that, I agree with that analogy that we actually haven't been seeing a lot of COPD and asthma patients, and I wonder if particularly the ones with more moderate disease are also on kind of medications to blunt their inflammatory response, and because COVID's such an inflammatory condition, whether or not that's offering some sort of protection for patients with COVID, particularly those who are on chronic steroids. But I definitely agree that those who have asthma and COPD aren't really leaving the house that much either.
You know, actually, that is an interesting question, and I was reading about that, and there does not appear to be a protective effect from the inhaled corticosteroids. So I think there's more to this, and I do really believe that there's a huge amount of avoidant behaviors. I can't comment on in other countries, but the amount of telehealth that we've converted to our elderly patients who have significant lung disease that I know have just been avoiding going out, and they've been doing the grocery shopping by, through our local grocery stores that deliver and all of those kinds of things. So I think in the fullness of time, we're going to get a lot more information. I think it's incredibly early for us to know. But I actually think that it is interesting because in Australia or in Melbourne, our patients just haven't been leaving the house compared to what they usually do. And our overall admissions, I think, for those diseases has gone down right now.
And also, I guess, the burden of overall viral respiratory illnesses. We haven't seen as much flu, we haven't seen as much RSV, we haven't seen as much viral illness, and that's definitely going to be having an impact. So everyone washing their hands, doing the right thing, wearing a mask is actually protecting the vulnerable as well. So I think we'll probably only have time for one question, which is very fortunate because we only appear to have one question from the audience. This is directed at John Zorbas. Anonymous would like to ask whether you use the plateau pressure to determine the PEEP high in APRV for COVID-19.
Yeah, so did we record the P-flat or the P-high? And we recorded the P-high mostly because of consistency through chart recall. So there were missing P-flat figures in some of the medical records that we had. You could argue that the T-high is so long and the T-low is so short that the P-high is very, very close to what the plateau pressures were when they were recorded. So it didn't make a significant difference. But it does bring up the question as to, what is your driving pressure in APRV? If you've got a patient breathing on top of your P-high, how are you determining is your driving pressure P-low to P-high? Well, no, because we know that the pressure doesn't fall to zero just because we set our P-low to zero and the T-low is so short. In a perfect world, I'd be measuring tracheal pressure in these patients, but that's prospective and invasive. So not a luxury we had, unfortunately.
Assuming to be aerosol generating as well.
Yeah.
I'm not sure you'll be able to get that one past ethics, unfortunately.
No, don't think so.
All right, so I think we'll wrap it up from there. Thank you very much once again to our three speakers. Very different talks, all really quite compelling. And please do stick around for the next round of talks on the very important issue of gender equity in intensive care medicine. Thank you.